Um, he's professor and director of research at Marshall University now. And I looked up, and this is a little bit crazy, but I read that you have over 90,000 citations on Google Scholar, which is pretty amazing.
Dude, very
Uh,
proud of that. Yes.
yeah, so hopefully you'll be able to distill some of that ACL wisdom into us tonight. And thank you for doing this. Thanks for taking time and take it away.
Thank you, Simon. I appreciate it. So, I'm going to talk to you tonight about biomechanics of ACL injuries and approach we've taken to reducing the risk. This is Carmen and Katie. They're my two academic daughters. They're both professors at Ohio State University now. And Carmen on the left is a PhD, MD, and Katie is an PT PhD. And they were in what I'm going to show you, our prospective studies at age 17. And they subsequently ruptured their ACL, both of them. Carmen on the left ended up having 11 surgeries on that knee. And the problem is, this is them receiving their terminal degrees at age 29, about 12 years later, and they both had cartilage resurfacing procedures. And the problem is, Carmen and Katie are more the rule than they are the exception. So, this is the approach we take, what we term preventative biomechanics. And we use this system looking at neurology, cardiovascular, genetic issues like ACL injury. I'll show you some of that data. What I'm going to focus on tonight is the musculoskeletal ACL injury and cartilage issues. And basically, what we do is we get the entire medical team involved, from the orthopedic surgeons to the primary care physicians to the physical therapists, athletic trainers, researchers, and we all work together to try to predict and prevent risk of these highly impactful problems. What we use is what I call a biomechanical epidemiologic approach, and many of those citations that Simon told you about were directly related to those biomechanical epidemiologic studies. So very difficult studies to do, and I need to cite the NFL, the NBA, the NIH. They've all put tens of millions of dollars into these studies.
Just look at my schedule just to give you an idea.
And basically, what we focus on is needy populations, underserved, adolescent, female, inactive, obese populations. And these kind of studies, what we do is we bring the athletes into the lab, we test them biomechanically, and then we let them go out and play, and then we follow them over many years. We've followed an entire county school system for over a decade, and then tracked those athletes who go on to injury to see, first of all, what are the predictive factors, and secondly, to take that information and use that to target interventions to hopefully reduce the risk of these issues. Now, exercise is the best preventive medicine there is. We all know this. It reduces the risk of heart disease by 40%, stroke by 30%, diabetes by almost 50, high blood pressure, reduced risk of mortality of recurrent breast cancer by almost half, colon cancer by 60%, Alzheimer's disease by a third, and it's the best pill you can buy. It's better antidepressant than drugs like Prozac or even behavioral therapy. So the American College of Sports Medicine stated a couple of decades ago, if we had a pill like exercise that had all those benefits readily available, we would prescribe it to every single patient. And I suggest that you do. Prescribe exercise to every single one of your patients. And the prescription is physical activity and preventive biomechanics. What are the downsides to this? Exercise does have downsides. There's risk of injury with exercise. So I've studied for decades the risk of myocardial infarction with exercise. Very rare in young individuals, but it's the #1 cause of sudden death in young athletes, mostly due to FHC, familial hypertrophic cardiomyopathy. I'm not going to get into that data, but we'll talk about some other genetic data. Overuse injuries. So we've published a couple studies looking at the incidence of, say, patellofemoral pain in young female athletes playing sports, pivoting sports like soccer and basketball and volleyball, and showed that risk is about 20 to 25% per season. I mean, the incidence is very high. Now, then there are other traumatic sports injuries that are less rare. And one I'm going to focus on today is ACL rupture. I should say it's more rare and more rare than patellofemoral. In the high school population, in young females, it occurs between, say, 3 and 6% prevalence, whereas in males of the same age, it's like 1-2% of the prevalence. And what we've done to look at this problem is we've looked at the mechanisms, and then we've done screenings based on the mechanism of how these injuries occurred. And then we've developed targeted interventions to directly reduce the risk of these exercise-related injuries. This is Rebecca Lobo tearing her ACL, and we'll talk about some commonalities to this mechanism. Again, we'll get into the mechanism in a minute, but what are the long-term impacts of ACL injury? Well, this was a study based out of the Boston group. This was an NFL-funded study where they showed that former players who tore their ACL, as expected, had about a 2-fold increase in musculoskeletal comorbidities like arthritis and knee joint replacement. The interesting thing and the alarming part of this study was they showed that there was about a 50% increase of myocardial infarction in former NFL players who also experienced ACL tears. Perhaps they suggested a systemic inflammatory process has begun with ACL injury that leads to downstream post-anti-inflammatory effects, maybe even surgically related iatrogenic effects. And this, again, highlights the importance of reducing the risk of these problems. So what I'm going to show you tonight is our 3-pronged, evidence-based, targeted approach to this. Mechanism and the evidence supporting ACL injuries, screening and risk modification, and then training with neuromuscular interventions. So if we go back to Rebecca Lobo, probably the best player in the WNBA at that time, she experienced an ACL rupture, and she never really came. She played for a short time in Houston. The reality is within a decade, she had about, this is Kate Webster and my meta-analysis of meta-analyses that we did on osteoarthritis post-ACL, about a 35% risk within the first decade of having significant radiographic osteoarthritis. So how does this occur? If you look at the entire body, what you see is this lower extremity valgus, or what we term biodynamically as knee abduction, meaning the distal tibia is away from the midpoint of the body. We're starting from the foot up biomechanically. She started with relatively low knee flexion. Most of her weight was on a single leg or single foot, and the foot is flat and rotated away from her midline. And then the center of mass of her body is lateral to her foot base. And there's sort of this uncontrolled movement, which was caused in large part by a perturbation at her hip and trunk. Now, if we zoom down on her knee, as we do here, what we see is this combination of knee abduction, anterior translation of the tibia, and internal tibial rotation. So if this is my fibula, basically what you see is abduction of the distal tibia, anterior translation of the tibia relative to the femur, combined with internal rotation, applied simultaneously, very rapidly, pop, within 30, 60 milliseconds or 1-2 frames of a video, the ACL ruptures. So what we've done over the last several decades is look at how these injuries occur. And this was the Quatman twins pushed a lot of this data forward during their PhDs. Basically, what we did is we took in vivo biomechanical full 3D motion analysis data of athletes, both prior to ACL injuries and after ACL injuries. We fed them into in vivo cardiac cadaveric studies that looked at could these kind of loads actually rupture an ACL in the lab. And then we fed that both types of data into in silico state-of-the-art computer models and demonstrated whether or not we could predict what kind of loads and who is at risk of rupturing their ACL. We fed a lot of data into these models, one being, as is here, MRI data, which shows bone bruises. And again, these bone bruises, if you follow them, they happen most predominantly in the lateral compartment on the posterior tibial plateau, the anterior femoral condyle, which again, that's when the high impact occurs, again, showing this mechanism of abduction, so lateral compartment, anterior translation, so posterior tibia, anterior femur, and internal rotation. So in combination, what you get is ACL rupture. So we've used this data in many studies to develop very high-level computer models using cartilage pressure distributions, using MRI, and basically what we have is forensic data for, as I just showed you, how an ACL injury occurs. So basically these results show a valgus collapse as the major ACL injury mechanism combined with tibial abduction, anterior translation, and internal rotation. So each one of these different luxations and rotations increases strain on the ACL. As you can see, anterior shear increases strain relative to the, we've done everything combined, looking at comparisons of different ligaments. Each of these increases strain on the ACL. But when you combine all three together, abduction, anterior translation, internal rotation, what you get is high enough strain to rupture the ACL. So even if you look at clinical tests, which are attempting to forensically reproduce the ACL injury, what you see is the most specific test for ACL rupture is a pivot shift exam. And what do you do during a pivot shift exam? The clinician applies a knee abduction, internal rotation, anterior translation force. That is reproducing the injury. So there's strong level 1 evidence of this mechanism of coupled tibial abduction, anterior translation, internal rotation, in vivo data, in silico data, in vivo data, literally hundreds of studies from our lab and many others demonstrating this. So this is the injury mechanism, and this is important because if we're going to figure out how to reduce the risk of these injuries, we have to know the mechanism. And importantly, anything that we can do to reduce one of these three rotations or luxations is going to reduce the risk of an ACL injury. So what we've demonstrated over the last couple of decades now is that there are parallel neuromuscular imbalances that relate directly to this injury mechanism. So this knee abduction relates to a neuromuscular imbalance I'm going to term ligament dominance. Low flexion relates to quadriceps dominance, the single leg aspect to the mechanism to leg dominance, and this increased lateral trunk motion to trunk dominance. This is an NBA player. Some of you might be familiar, coming from the Boston area and the Celtics. Here he is. He's got a single leg valgus on an extended knee demonstrating leg, ligament, and quadriceps dominance. We also, using these biomechanical epidemiologic studies, developed tools. So, for example, we took an entire team of young basketball players. At that time, I had labs at University of Kentucky, Cincinnati Children's Hospital, and Ohio State. And we brought them into all three labs and tested these young athletes across and in all of these laboratories just to look at the reliability, reproducibility, and validity of our measures. Now we go from young female athletes to an NBA athlete again. Valgus, extended knee, ligament dominance, and quadriceps dominance. What you see is boom, straight, and we'll talk a little bit more about this. So knee abduction relates to ligament dominance, low flexion to quad dominance, single leg to leg dominance, lateral trunk motion to trunk dominance. So these young athletes, thousands of young athletes that we screened and we fed in, this was the first initial study that we, on prediction, that we published now 20 years ago, where we showed that those young athletes who went on to an injury had about 8 degrees more abduction of their tibia relative to their femur and about 10 degrees less flexion. Really good predictors. Now, in the transverse plane, rotation is a little difficult to pick up because you're only talking a few degrees within error. But if we look at just the knee abduction angle, just that distal tibial abduction angle relative to the femur, the X's are those that go on to an ACL injury. As you can see, this is actually quite sensitive and specific. It's about 80% sensitive and specific for those athletes who go on to an ACL injury. But more importantly, if you look at the spread of the data, somewhere between a half and 2/3 of these young athletes, these are young female athletes in high school and college, at relative risk of an ACL tear. So again, looking at these neuromuscular imbalance, ligament, quad, leg dominance, and trunk dominance. This is my favorite sport. I don't know if many of you have seen this or not, but it's WWE and female athletes. She just ruptured her left in the back. She just ruptured her left ACL. What you have to do is notice, look on the left-hand side, see that the glute activation, see that pelvic drop, see that trunk movement. She ruptures her ACL. So no matter what sport you look at, if you're looking at many different sports, for example, see if we can get some of these to play. So this is team handball, which is a really high risk sport for ACL injury. What you see is this common mechanism of each one of these athletes is attempting to stop with a flat foot, pivot across their body, perturb their trunk, fake out their opponent, throw the ball around them. And basically what they're doing is recapitulating the injury mechanism of this trunk perturbation, whether it's induced by themselves or someone else, combined with a flat foot with a relatively straight knee and valgus because of the trunk movement over the lateral to the leg. Now, one athlete that we know is relatively resistant to ACL tears is a gymnast because they have great core control over the foot base. But even a gymnast, if she loses control of that center of mass and where it is relative to the foot base, she's in trouble, ruptures her ACL. So this is what it looks like in the laboratory. Basically, what you get is you get an athlete dropping down off a box, and what you see is you get this asymmetric torque on both sides. And basically, you see the same thing you do on the court, which is flat-footed. You let the trunk go lateral to the hip and knee, which creates a torque, a abduction torque at the knee, adduction torque at the hip, and you rupture your ACL. Now, what we showed in the lab is we could actually change this profile, that we could alter and bring those forces across the center of, in the center of the knee, and give the athlete the analysis and feedback to demonstrate this is what you're doing. Bring those forces across the center and the hip and the knee, flex your hip and the knee. Do not allow excessive frontal plane motion. Do not allow excessive internal rotation, and you can reduce the risk of these injuries. So again, this is very important. The trunk is absolutely crucial. This is a study of almost 300 Yale athletes where we looked at core stability and proprioception. And actually, Jacek Kolowicki, who did these original studies, was looking at the association between trunk proprioception and control and future risk of low back pain in this cohort of Yale athletes. And what they showed was there was a slight association. They published this in the journal Biomechanics. I read the paper and I called up Jacek, and I were actually sharing a PhD student at the time, Billy Zazalak, and I said, do you guys have the data for knee injuries on this, not just low back pain? And we checked with the team physician and the athletic trainer, and they'd collected all the injuries. So this was kind of a serendipitous, very cool study because there were no biased preconceived notions or hypotheses directed at the association between trunk neuromuscular control or trunk proprioception and future knee injuries. It was strictly looking at low back pain. So what we found post hoc was those athletes who could not reposition themselves, didn't perceive the center of mass well and where its position was in three-dimensional space, had significant risk of knee, ligament, and ACL injury, especially if they were female. So we go back again to the NBA, and what you see, this lateralized trunk, the control of the core, again, in this case, perturbed, but regardless, what happens is when you get a ground reaction force from the foot is directed at his center of mass, as it is in any athlete, as he lands, ground reaction force from the foot. Now, when you have a high ground reaction force, high distance, force times distance is torque, you have a high abduction torque that ruptures his ACL. And this was a series of studies we did with a large group in Philly and Boston and at the NIH. And basically we looked at every ACL injury video that we could find anywhere. And basically in every case, we saw this lateral trunk lean that led to valgus collapse, that led to ACL injury. So what we did is we developed tools. So tools for primary prevention. We just did baseline evaluation using simple wall jumps and looking at an athlete's body habitus, control, hip and knee, as they did just simple techniques. And then as we developed, for example, she's preparing for a broad jump, we looked at those athletes who actually use their muscular system to actively recreate this dynamic valgus position. And those are the most difficult to retrain and reduce the risk. And basically what I'll use is an analogy here. So the idea is once these athletes, high-risk athletes, have growth, okay, so for example, males and females are both at relatively low risk of an ACL injury when they're pre-puberty or pre-adolescent. Once adolescent hits, now adolescence hits in young girls about a year and a half to 2 years earlier than boys. So they get these longer levers, they have more body mass, so they have higher forces. And if they don't have a relative increase in power in their hip and knee musculature and strength, they get a decrease in neuromuscular control. They get an increase in dynamic valgus. They get an increase, a high joint load, this increased knee abduction moment that I've been showing you throughout these studies, and increase injury risk. So if we use a car-based analogy, just to simplify this, so boys and girls start, say, with a Prius body of the car, a Prius chassis, let's call it, with a Prius engine. And the engine and the chassis are matched. The engine has enough power to control the chassis. What happens after the growth spurt? So you got longer levers, the tibia and the femur. You got a longer trunk where there's more mass. The mass is displaced higher off the ground. So it's almost like you have more mass on stilts. So it's higher, more difficult to control. Now, we've done these studies, and I can show you these in many different ways. We've done these studies longitudinally in the same athletes. We've done these cross-sectionally in massive number, thousands of athletes. It all looks the same. What you get in young females is you get increased chassis. So you're going from, say, a Prius to a Malibu car. So you got a bigger chassis, but with somewhere between a Prius and a Malibu engine. So you get a mismatch in relative power output compared to the size of the chassis. Whereas in males, what you get is you get a bigger chassis, say even larger than females on average, say a Cadillac sized chassis, but you get a disproportionately more powerful motor or engine. So you get a Cadillac chassis body with a Porsche engine. Now, how do I know that? It sounds ridiculous. Well, here's how we know. Great measure of whole body motor power is vertical jump height. And we do vertical jumps on all of our